We have our friend and esteemed guest today, Dr. Marie Smith, who is a professor and assistant dean for practice and public policy partnerships at University of Connecticut School of Pharmacy. In 2010, she was named the first recipient of the Henry A. Palmer Endowed Professorship of Pharmacy Practice and previously served as department head of pharmacy practice. In 2013, she also served as senior advisor to the CMS Innovation Center to develop a national strategy and implementation plan for integrating pharmacist-provided medication management services in the Regional Comprehensive Primary Care Initiative. Dr. Smith collaborates with policymakers, healthcare organizations to address primary care expanded workforce opportunities, medication optimization and management services, and payment for pharmacist clinical services. She also is an affiliate faculty of CPPI. We are lucky to have her, and we have collaborated in several exciting opportunities. Recently, our invitational summit on state Medicaid payment for pharmacy clinical services. And today she brings to us a presentation titled Improving Collaboration Between Primary Care Providers and Community Pharmacists in Connecticut. Without further ado, thank you so much, Dr. Smith, for presenting today, and I'll turn it over to you.
Great. Thank you so much, Teresa. And it's great to see a lot of familiar names in the participant list. So welcome to those of you who we've worked with or talked with before. Today, I'm going to talk about a survey, some survey research that we did in 2021. It was an honor student project, and the title is Improving Collaboration Between Primary Care Providers and Community Pharmacists in Connecticut. And this is all the information you might want to just take a look at here for claiming CE credit. You see the code. The code expires in 48 hours. And here's the information regarding the CE requirements. And as a speaker, I have no disclosures for the topic we're talking about today. So let's start with a polling question, just so I can get a sense of who's working or who's in the audience is working in which setting. So if you could just put in the chat your answers: A, academia; B, community pharmacy; C, hospital pharmacy; D, ambulatory care clinics or office-based practice; and E, other. And I can see them coming in, and Sydney's going to give me a readout here of what the common answer is.
Yeah, we have kind of all over the board, some in academia, a few ambulatory care, some others. Yeah, a good bit all across the board.
Great. Good, that's great. So we've got kind of a diverse audience in terms of work setting. Poll question 2, do you or pharmacists at your practice site, assuming you are in a practice site, do you use collaborative practice agreements with community pharmacists? Yes or no? A, yes; B, no.
Mostly A.
Okay.
We have a B, another A.
Okay, good. That's helpful because I'm going to provide a little bit of context for you. If we were answering from Connecticut, most participants would probably say no. So it sounds like you have several examples in your state or your practice setting where you can say, yes, community pharmacists are using collaborative practice agreements. The basis of the presentation today is really going to be a high-level overview of findings from a study that we conducted in 2021. And this is the citation for it. It is published. And I did want to provide that. And if you have more in-depth questioning or things you think about that you'd like to know more about it after the presentation, this may be a place where you could go and get more detailed information, and as well as feel free to reach out to me by email. I'll give you that email at the end of the presentation. So I want to start with this map. It's an APHA map that I believe is updated through about August of last year. And it's a great map that I find useful in many audiences to talk about payment for pharmacist services. And you might say, gee, why? And many of you have colors on your states. You'll see that in Connecticut, we are the state right here. We do not have any color, and that's because we have no payment for pharmacist services in Connecticut from either public or commercial insurers. I'm pleased to say that the first time this year in our session, which is ongoing now, our legislative session, we have for the first time a representative who is a pharmacist, and that has made such a difference, as I'm sure many of you know in your own states, to have that kind of advocacy internal in the legislative body. And we do have two proposed laws that would provide for pharmacist services. So we're staying tuned, crossing our fingers, but that's the context that you need to know with regard to maybe some of the methods and some of the findings that we will present, or I'll present. The objective of our study was to survey Connecticut primary care providers. And in the state of Connecticut, primary care providers are physicians. They can be MDs, DOs, APRNs, and physician's assistants, PAs. Some geriatricians will identify themselves that way. It depends which database you use. But overall, we were looking to describe the current type and frequency of communications between PCPs or their office staff. So that would include RNs and nurses and you'll see abbreviated MAs, medical assistants. What types and frequency of communications does the PCP or their staff members have with community pharmacists currently? Second, we wanted to characterize PCP perspectives on establishing medication monitoring services provided by community pharmacists between PCP visits. And the third objective was to determine PCP perspectives on the use of collaborative practice agreements with community pharmacists. In our state, just to provide again context, in our state since 2012, so approaching almost 15 years coming up, we've had very broad-based collaborative practice authority in our state. Most of the activity using CPAs, though, does get implemented in hospitals or academic outpatient clinics. It's very rare that it is done with community pharmacists. And so we were interested in kind of characterizing that as a baseline for our state. So the methods. Many of you who do survey research, you know it has limitations. And if you've ever tried using a licensing database, which was primarily the only source that we could get at low cost, meaning free for a student project, and also one that was relatively easy to get, we would normally go to the licensing database. And so we use the Connecticut licensing database for physicians, APRNs, PAs. The inclusion criteria. So our target was really to get responses from PCPs with active licenses and were currently practicing internal medicine or family practice in the state of Connecticut. The limitations we encountered are that our database is primarily transactional for licensure. It is not much of a database that gives us a lot of in-depth information other than the fact that they paid their licensing fee and whether they're currently active, inactive, and that sort of thing. So there was no information we had other than their names, their practice sites, emails. We had no information whether they were retired, part-time clinicians, no longer practicing in the state, or no longer working in primary care. So we had to design our survey and use screening questions to determine who our study population was going to be. And this was all optional and volunteer, of course. The survey was an online survey, so it's cross-sectional from 2020, the end of 2020, into the beginning of 2021. And that's important because that time frame, certainly, as everyone knows, was in the COVID period. And, certainly there was a lot of activity going on of offices closing, primary care clinics closing. We chose to wait until the end of the year into the beginning of 21 because we knew that the activity of seeing patients and offices practicing was coming back in the fall of 2020 somewhat, and it wasn't back to normal, but given the constraints of an honors project, that was the best time frame for us to survey. The survey had 4 domains. You can see the domain topic areas, demographics, characterizing the communications currently, the perspectives about a scenario that I'll describe to you about community pharmacists, medication monitoring, and the perspectives on use of collaborative practice agreements with community pharmacists. As a result, we had about 782 surveys returned to us within about a 4-week to 5-week period with 3 reminders in that interval of time, which quite honestly, I was very pleased with, given the constraints and the environment of COVID. Of those, though, we had to use, as I said, screening questions to really identify who met the inclusion criteria. 206 were ineligible based on those criteria. 354 were incomplete for analysis. So that left us with a convenient sample of 222 completed surveys. So that's really what I'm presenting today, is this surveys completed data. So the first thing we looked at was demographics, and we saw that by discipline, we had 46% APRN respondents, 41% physicians, and we thought that was pretty good, although I think it's good as a response rate, but overall, it's probably skewed a little bit higher to nurse practitioners. If you looked at the total licensure, they would exceed 46%. Usually the ratio that we see here in Connecticut is for 1 MD or DO, you will have probably 2 APRNs. So we knew that it was skewed a little bit there. The other setting site that we were looking at, we looked at office-based, community health centers, hospital outpatient clinics, and then other catch-all. And I believe this is what I expected to be more evenly distributed. 57% of the respondents came from office practices, so keep that in mind. Practice size is always a factor, and so we looked at that. You can see that small, medium, so 1 to 3 would be considered small, medium would be 4 to 7. They were somewhat equivocal, and not a lot of large practices in the 8 to 11 and the 12 or more. So what we did is, for analysis purposes, we actually grouped the 8 and above, which would have represented 36%, into a segment and called them large practices. The specialties were equivocal between family medicine and internal medicine, and years of practice is something to note. Roughly 60% of our PCP respondents had less than or equal to 15 years of practice, and 40% were 16 years or above. The first set of questions really tried to describe what is the current communication between PCP offices. So it could be the PCP and or the staff members, mostly RNs and MAs. What type of frequency was there with which type of pharmacies? And so you can see that distribution here, 29% chain pharmacies, 17 mass merchandise, grocery stores, independent pharmacies, and mail order. And that seemed fairly appropriate given the distribution of chain pharmacies. We have a predominance here. Well, let me say, in the time frame of the survey, we have a predominance of chain pharmacies, primarily CVS and Walgreens are our major chains. There are a couple of regional chains as well in larger cities. We also asked what was the frequency that the PCP office communicated with community pharmacies, and overall the average was 47% said once weekly. Large practices, which we defined, as I mentioned, 12 or more PCPs, 51%, small, medium, less than 12, 43%, and there was a significant difference there. The next section and domain focused on how can we characterize the communication topics that occur between a PCP office and community pharmacists. And we looked at 4 different domains that I will, or I shouldn't say domains, but types of communications. And I'll list the frequencies. But one of the things we wanted to do was we wanted to really also give the opportunity to have them respond that they never call. So if we look at the first topic area of product-related questions, so specifically communications about a drug product, not related to any specific patient, so product only, 37% responded that they never called the community pharmacy about that. And of the ones who did, then there is the breakdown of what do they contact the community pharmacist about. So you can see high numbers for PCPs contacting the pharmacist about drug-drug interactions, dosages, and new drugs. RNs and MAs usually contact about whether a drug is available, is it in stock? And that showed a significant difference. The next section we wanted to look at is the topic of prescription-related communications. So questions that or conversations about the actual prescription. PCPs never calling, you see, is 36%. And of those that did contact a pharmacist, PCPs contacted them about medication substitutions and refills, whereas RNs and medical assistants had a little bit more differentiation. They would be the person who would contact the pharmacist about prior authorization questions and also some questions about refills, which again was a difference in their roles and their communications. The next topic was patient-related communication. So this had to involve a question relating to a specific patient. Never calls were highest for never calling about patient affordability or copays. And of those who did call a pharmacist, PCPs tended to call more for refill information, refill history information, adherence checks. RNs, MAs did some of that as well. And they also indicated they called for patient affordability and copay information. And you can see, again, role differentiation there is significant. The next, I believe this is the last topic area we had, was to what extent are communications addressing issues around what we would call med optimization. So we broke this down very specifically, and you can see some of that there. And we first tested individually to see how much of the response was they never call. So you can see the never call about medication monitoring was the highest response, followed by comprehensive med reviews, med therapy planning, and med reconciliation. When the office staff or the PCP called about med optimization topics, physicians would usually tend to call more for medication therapy plans and medication monitoring, and these would be patient-specific questions, whereas nurses and medical assistants contacted mostly the pharmacist about medication reconciliation. So that was the first section of our survey. Now we switch to presenting information that would help us to get a better sense of what PCP perspectives were about community pharmacists monitoring services. So we presented a scenario, kind of what I would call a mini case of a patient who had medications for diabetes and hypertension. We gave them a specific drug, specific dose, and presented the opportunity or the perspective of the scenario, the community pharmacist would offer patient services between PCP visits that included 3 types of functions. One would be performing monthly blood glucose and blood pressure monitoring, sending monitoring reports to the PCP, and providing the PCP with medication recommendations based on those monitoring results. And once presented with that scenario, we asked a series of questions. The first question we asked was around just generally to what extent were they aware that a pharmacist, community-based pharmacist had the capability to monitor blood pressure and diabetes medications. And average was 34%. And you can see the breakout there. 42%, the highest, came from PCPs that were in primary care hospital-based clinics, a little bit less, 1% with office practice-based PCPs, and lastly, 36% with community health centers. This is significant. We were not surprised by it because, as I mentioned in the opening remarks, the context is really important for our state. There is no provider status. There is no billing and payment. And most of the activity between a primary care physician and the pharmacist interaction is going to occur primarily in academic-based settings, or we have 2 settings that are with the Veterans Administration. And for the most part, they would, a PCP in an office space, as you remember the setting, we had a higher percentage of office space, they would not necessarily know about this or be aware of capabilities. We wanted to drill down a little bit more on that scenario for community pharmacist monitoring, and we asked some questions around how comfortable would the PCP be implementing such a service that was described between PCP visits. You can see the frequency overall was 66% responded they would be comfortable. However, when you did another sub-analysis, it really was strikingly different because it really related to the fact that what was driving that was PCPs who had less than 16 years practice experience. Those were the most comfortable. Same we see for pharmacists reporting. The question would be what were their perspectives on pharmacist reports and actionable recommendations to improve patient outcomes. 79% thought that would occur or could occur in the scenario. However, when you looked at the sub-analysis, it was PCPs who had more frequent training and less than 16 years practice experience that had the higher level of agreement. We then looked at facilitators and barriers. What would they identify as facilitators and barriers? So the most common facilitators to this community pharmacist monitoring service were that they were receiving patient feedback that was positive, that the reports were timely, and they received that timeliness of the data between PCPs, and that improved patient outcomes were seen with pharmacist recommendations. So I don't think any of those findings are surprising. The asterisk is you can see the difference between the breakout in practice setting between for timeliness of data between PCP visits, and you see that there's a higher percentage of positive facilitator response with community health centers and office practices than you see with hospital clinics. Significant difference, however, I think explainable by most of the clinic-based pharmacists that are in primary care clinics there have been in place. Those tend to be more academically oriented sites. So, that's probably the issue of why they were a little bit more inclined to respond that way in terms of being a facilitator. They've already got clinical pharmacists that they work with, and they probably are hospital-based pharmacists. They would not be as excited about, the timeliness of data because they already are seeing that. When we look at what happens with years of practice, the PCPs who had less than 10 years of practice indicated community pharmacist access would be a facilitator, provided that there was access to the EHR. The pharmacist had access to the EHR. That was the facilitator. If we look at barriers, there were, again, 3 main barriers identified: lack of pharmacist dedicated time, lack of experience in monitoring and providing recommendations, and lack of access to the patient's EHR. We then looked at size of practice to see what was driving that, and PCPs in larger practices stated that lack of access to the patient's EHR was a barrier. And the other finding was that regardless of practice setting, PCPs stated lack of access to the EHR was a barrier. So both practice size and practice setting, the major factor that they identified would be the lack of access to a patient's EHR. So let's do a poll question here. Which of the following is not a facilitator for community pharmacist monitoring services? 1, timely and actionable pharmacist notes to the PCP, improved patient outcomes, positive patient feedback, or on-demand availability of a community pharmacist.
Don't see anything yet in the chat.
Okay, all right.
We have a D.
Okay.
Another D. Yeah, I see 2 Ds.
Okay, all right. And that is the correct answer. So that's good that we got a couple of people who believe that. The A, B, and C are all identified as the most frequent facilitators for that service. So let's move on and talk about PCP perspectives on using a CPA, collaborative practice agreement, with community pharmacists. So this was the last part of the survey section. And the first item there, we looked at perspectives, again, of PCPs, and then looked at facilitators and barriers. So the first perspective that's listed here is across all practice settings, the awareness of a community pharmacist's ability to provide direct patient care services with a CPA. Only 31% were aware of that service being available. And again, if you look at practice settings differences, that was significant. Would use a CPA with a community pharmacist for monitoring and managing meds between visits, 49% overall frequency. And when we looked and did sub-analysis, again, it was PCPs who had less than 16 years practice experience were more comfortable doing that. In terms of agreement that community pharmacists would make appropriate medication adjustments to achieve therapeutic goals and improve outcomes between PCP visits, 57% overall. But again, 16 years of practice and less was significant for those PCPs that were more comfortable doing that or agreed with that. And the last item was CPAs with community pharmacists would decrease PCP workload burden for managing patients with diabetes and blood pressure medications. 56% overall frequency. However, again, when you drill down, it was really related more to practice size. So 70% of the PCPs in large practices showed a significant difference. If we look at the facilitators to using CPAs with community pharmacists, there were 4 factors, main factors. One was timely monitoring reports between the PCP visits. Second was improved patient outcomes, positive patient feedback, and community pharmacist was viewed by patients as a member of that primary care team. If we looked at again, what were the differentiators that significantly affected the response there? PCPs with less than 16 years experience stated that their ability to see more patients with new conditions and concerns was a facilitator. So that did show up, but it was only under the sub-analysis. And let's look at barriers. So barriers overall included lack of pharmacist dedicated time, lack of pharmacist training and experience with CPAs, poor documentation in the EHRs, and patients not viewing the pharmacist as a member of the primary care team were considered barriers to using any type of collaborative practice agreements with community pharmacists. And if we, again, looked at the sub-analysis, regardless of practice setting, but we analyze that by practice setting, PCP stated that lack of pharmacist dedicated time was a barrier. And I think it's remarkable that, remember, this was done in the end of 2020 and the beginning of 2021. The researcher in me would say, gee, what would happen today if we asked similar types of questions? What we have experienced, like I'm sure many of you, is community-based pharmacies. Many of our chains, large chains, have closed stores. Our independent pharmacies have also either changed in terms of reducing hours or they have closed. And we've seen it now with our large national chains also reducing hours. And as I said, they have closed stores. So just remember, this was in 2021. My sense is if we were to go back and analyze this more or conduct focus groups, this item would come up again, is lack of dedicated time. And we talk about access, an access point being in the community. However, I don't know if that's shifted in Connecticut or not, but I sense the more recent actions in the past 6 to 12 months may influence that in a different direction. So polling question 4, which of the following is not a barrier for community pharmacist monitoring and management services? A would be poor documentation of the patient community pharmacist visit. B, electronic health record access to read PCP notes and labs. C, pharmacist not viewed as a member of the PCP team. Or D, negative feedback from patients.
Couple D's.
Okay.
Another D. The majority is D.
Okay, good. And I think what we found is the most common barriers were A, B, and C. So D might seem negative feedback is not something you would really want either, but based on our work, A, B, and C would be the most common ones. So with that, what are the key messages? Well, I think the takeaways for us were that still there was a high level of PCPs who were unaware of community pharmacists' capabilities to monitoring and manage chronic medication use, and 31%, only 31% were aware that we even had the ability to use a collaborative practice agreement in the state. Facilitators, you can see there, feedback from patients, timely data between PCP visits, looking at how the recommendations of the pharmacist would improve patient outcomes were certainly identified as facilitators. However, we see now this dichotomy between PCPs who have less than 16 years of practice experience being more comfortable with community pharmacists, monitoring between visits, sending actionable recommendations, making appropriate medication adjustments. And the same thing we see is with the stated ability to see more patients as a facilitator, meaning that PCPs who have less than 16 years experience would find the services that are described above that a community pharmacist could perform to be more of a facilitator that would help them in their workload, perhaps PCP shortages, those sorts of things. The barriers, most of our respondents perceived community pharmacists do not have time to monitor patient medications. And again, I think it's remarkable that this was done in 2021. I believe that, I wouldn't be surprised if there was a higher percentage that said today, if we were to do this, that a higher percentage would have that same perception of what they perceive is that community pharmacists are busy. They're maybe overworked in their clinic, in their workflows, not as available maybe to do these types of services. And that seemed to be coming from PCPs across all practice setting. That dedicated time was a barrier. Most of them, again, 69%, were not aware that community pharmacists even had the ability to practice with a CPA, and 64% of PCPs stated that community pharmacists' lack of access to the electronic health record would really limit that use of that service. So what are the takeaway implications from what our findings were? Well, I think there's certainly a lot we need to work on with greater awareness of what the capabilities are, what the clinical training is of pharmacists, and do that. We talk about that in some anecdotal or maybe organizational levels. Within pharmacy, we're aware of it, but this made me think that we need to do a better job in our state and work with our state pharmacy associations to present at state meetings, look for opportunities to talk outside the state whenever possible, maybe even start writing and using journals that PCPs, physicians within our state may look to for information in general. The second point is promote and pilot services in community practice settings, especially maybe in areas where there's a preponderance of practitioners who are newer practitioners. And I say new, meaning, I think although we didn't get into a lot of detail to say this, I would say that from other work we've done, anecdotal information, and some focus groups we did back in 2012 to 2015, what we were hearing in those instances was that younger, by age, younger PCPs, usually under the age of 45, which is not that different than saying years of practice. It's about that level of about under 45 years of age. We saw that they were trained more in team-based inpatient environments, and they may be more willing then to know what a pharmacist capabilities are, what their clinical training is, whereas those who have practiced longer and maybe weren't trained in that same professional model or interprofessional model don't have the understanding of what our capabilities are. And I think on our awareness level, also we can promote services to patients and to make sure that when we do that, that they are seen as part of pharmacists are seen as part of that primary care team. That was a message I think that came across in this survey. If we look at what are some implications in the workplace, we have the ability to use collaborative practice agreements. As I mentioned, they're used primarily in a hospital or academic setting. So establishing CPAs with PCPs for referral processes, and we're still working, as I mentioned, on the payment model. I think those are factors that are going to affect the implementation of CPA use between PCPs and community-based pharmacists. Certainly, we heard in this the need for more dedicated pharmacist staffing. They did not say with patient appointments, but from an implementation standpoint, having patient appointments that we saw was pretty successful in community pharmacies during the COVID period for vaccinations. Might be a good model that people can relate to, certainly the public as well as perhaps our colleagues in primary care. And then lastly, EHR access to read notes, medication lists, lab values, and to write and document the pharmacist visit is another factor that could be a change that would be needed in the workplace. And the last point is alignment with value-based payments. Again, for context, we are a state that is still driven mostly by fee-for-service, both in Medicaid and in our commercial health plans. So as the move is shifting towards value-based, and I'm talking about meaningful value-based payments, such that it's a meaningful amount of compensation to the primary care group or the practice or the health system, clinic system, until we reach that point, that tipping point, which we are not there yet. It's going to be difficult for primary care providers to look at, what value and alignment we bring to that kind of equation. So, there is, as we move towards value-based payment, we are going to see the opportunities, I believe, as most of you have probably recognized as well, that we can make a difference in improving outcomes and achieving therapeutic goals, especially for chronic diseases. Hypertension and diabetes would be very low-hanging fruit in my mind. The ability to open up more appointments to see patients with acute and immediate needs in primary care so that the workload burden, the clinical workload burden can be shifted to someone like a pharmacist with our training. This comment here about 1 FTE pharmacist with a CPA can open up 1,900 appointments per year. That was not part of our study, so I don't want to convey that. But we've done additional work that we've presented and published that shows that in a primary care office where they have had an embedded pharmacist for probably going on about 6 years now, and also in an FQHC, we analyzed that, and there certainly is the ability to shift workload. And the last point is, as I mentioned, we are doing from an advocacy standpoint, from a legislative standpoint, we have opportunities ongoing now with proposed legislation that would look at pharmacists being paid for these types of services by public payers and also by commercial health plans. So I believe that is the last slide. I would be happy to hear your thoughts, suggestions, maybe some of your work that you've done in your states, if there's anything similar that you might want to share as well.
We have a comment or question in the chat. Marie, would it be possible to also share that additional work where you found the 1 FTE pharmacist with CPA can open up?
Yes. So I'll be happy to share that with you. It is published. I want to make sure you understand, though, that it's published in RSAP, and I want to say it's about 2017, 18. I'll be happy to, I'll send that along. I'm to get out of where I am and get that and put it in the chat right now is kind of not convenient, but I'll try to listen to maybe another question and go get that. But if not, Sydney, I can actually send you the article if there's a way to post it.
Yeah, absolutely. If you just want to send it to me, I can send it in the follow-up thank you email.
Sure. Yeah, that's great. We can do that. Let me just caveat that. It is written more as a research methods paper. So you will need to really look through it. It describes things from a methods perspective. So it shows you the calculations and all the methods to derive that. But someone may find it useful if they're doing some similar research. I'm really interested in knowing those of you who are in states that have active participation of PCPs with collaborative practice agreements in community pharmacies. How did this information strike you? Or another way to think about it is, what were some of the facilitators maybe that you used or barriers you had to overcome when that process of implementation started?
Looks like Keenan Reyes has her hand raised. Feel
Sure.
free just to unmute yourselves too and ask questions if that's easier.
Thanks, Sydney. Yes, Marie. So in my experience, I'm a fairly new graduate, but when at my previous role, I also noticed that one of the facilitators that you mentioned is our younger providers, or they're newer out of school. They were definitely more on board with me helping with managing their patients. So it took a little bit more convincing for our more seasoned providers at that office, and it was a smaller office as well, less than 12 providers. So I definitely agree with those facilitators for sure.
That's good. I'm glad to hear that. Do you recall any of the hurdles or the barriers with the, let's say, more experienced PCPs? What would you work on first or suggest that you have to think about as you approach that?
Well, what was really great for us is once, because it was such a small group, we had a lot of follow-up meetings where all the providers were present. So once they started seeing some of the success and the praises that the younger providers or the newer providers were seeing, they were like, well, maybe we'll look at it again.
Right.
So that helps. Starting again, I've always heard a provider champion is really the best way to get started. So if you have one that you're really interested in, or who's really interested in the pharmacist services, we really capitalized on that and shared that improvement and that success at our meetings. And that tended to pique a little bit more interest.
Yeah, no, I think you can use peer pressure. That sounds exactly like what I've experienced. But it's good to know. What was that in a true community-based setting, or was it academically oriented?
So this was at a provider office, a primary care provider office that was associated with a small community health system.
Okay.
So it was not academic. That was purely primary care provider office based.
Right. Yeah, that's great. That's good to know. I will say that I mentioned the one FTE can open up 1,900 pharmacist patient appointments per year to decrease the PCP workload burden. In that study, we did a fair amount of qualitative work as well. And this was somewhat academically, it was affiliated. It was an academic health system affiliation, large PCP group. And they had by the time we were doing our research there, they had an initial pharmacist embedded in the practice for, I think at that time, it was probably 3 years. It was their initial clinical pharmacist, and that person moved out of state, and then they recruited another person. So by the time that we were there, they had at least 4 years experience with a pharmacist embedded in their office practice. And it was remarkable. And when we did some of the qualitative interviews with PCPs, they were very candid. And what they told us is we were really, even the practice leader who was the champion mentioned that we were really reluctant at first to know how we could even utilize the pharmacist that pharmacist had clinical training and had 2 years of PGY 1 and 2 ambulatory care practice experience by the time they came, had come from Oregon, had been using collaborative practice agreements for many, many years out on the West Coast, had a lot of experience. And the physician group was reluctant, but at least open to, having that initial pharmacist. And the comment from the practice leader was, we really didn't know what that pharmacist could do that we as physicians or our nurses could already do. And then once we had the pharmacists working in our office under collaborative practice, saw that they were able to manage a panel of patients that, we decided what the most complex patients were to refer to them. But we were actually surprised, and our role in that research was to basically document the impact of the pharmacist and the embedded pharmacist on patient outcomes. And no one had done that in the 4 years that they've had a clinical pharmacist there. And we were able to present that work to their administration, as well as, their health system, population health folks, and whatever. And it was the first time that they saw an analysis done, and anecdotally said, quite honestly, we now refer all of our patients who have chronic diseases, primarily hypertension and type 2 diabetes. And the outcomes were actually better with the cohort that was seen by the clinical pharmacists versus the PCPs. So I think what I take away is your comment about, they need to see the outcomes. They need to see the data. However, it's so difficult for many pharmacists to be both implementing the service and doing the research. So if you find that you can't do both, and there's an academic partner that maybe faculty members that are interested in doing such research, that's another thing to think about.
It looks like we also have another comment. Annette Grant, I know that you wanted to raise your hand, so just wanted to give you that space to share if you'd like.
Sure. Happy to do so. Can you hear me?
Yes.
Okay. So I think, and I'm speaking from Kansas Medicaid drug program perspective here, joining you today. If I go back to just my different settings, I think hospital, very easy to become part of the team. That to show your ability to contribute, I think that's very, much easier. I think like I think somebody was talking about maybe a rural health clinic or a federal qualified health clinic. I think those are the settings that's easier to contribute. All you have to do is start speaking and talking to people and sharing your knowledge and recommendations or whatever, and eventually, they'll catch on that you can contribute. And I think those settings are easier. I think with the retail, the biggest problem is that as much as you do intervene, there's the time to document is not there. Like I would just print off a sheet and write my notes, who I called, what they said, the changes we made. But you get to the end of the night and you just, you don't have time to document everything you do. And so I think what we do, and I noticed your states, our color is purple, but or plum, whatever color you want, but it should be that turquoise color. Fall of 2023, we made pharmacists as providers where we can reimburse some certain services that the state reimburses. So, excuse me, it's been a little while, and we add services as our state legislature adds services. That we reimburse for the pharmacists for those services. We have had for a long time, back to 2013 for sure. So over 10 years where we do our managed care do pay pharmacists for MTM services through those common vendors, the outcomes and RICS. I don't know if RICS is still around, but definitely outcomes. Our goal is eventually have those become so the services I told you that the legislature allows them to do, clinical services, those are being billed on a medical bin, CMS 1500 form. So they can bill the state for those. Our goal is to move the other MTM that goes through a third-party vendor to the pharmacist just billing the state directly through a medical form for those services that they do. So that's our goal. And I think while I think as independent pharmacists can, in a smaller community, can reach out and brainstorm and work with their local partner providers. That's a lot of work, and they can do that. We have some CPSN, I think is the organization, pharmacists that do that. But I think the hardest part is the majority of pharmacists are in the retail setting that can provide the most impact by volume. If you think about all the interventions that they do, it's just the problem is that interaction with the physician is real time questions, solving things, and and so it's just, the physician, like the pharmacist, is going through the day just trying to get through the patient, you know what I mean? Just trying to get through the workload.
Yeah.
And I just think that makes it less like them to know the difference. But at the same time, when I worked well with the physicians and made recommendations and they took it, then the following Saturday morning, when there's nobody there and I have to, one other person and me, and work in 3 windows, the drop off and the drive through, and I'm at the drive through, they're like, Annette, what are you doing running the drive through? And it's very embarrassing because I've helped them during the week with their patients and the problems I brought up, and and they were happy for my suggestions or catching an error, whatever it was. But the problem is, then you're at the drive-through, you know what I mean? You just can't, that setting has so many problems. There's the basic dispensing function, which still filling the script correctly and making sure there's no drug interactions and duplicate therapy and all that. That is key to everyday patient health. And yeah, we can take the blood pressure and we can do some of these other things, and I don't discredit those. But to your comment earlier, the physicians and nurses are saying, well, we can do that, to do something that we can't do. And that's where we are supposed to be the drug experts. And to me, that's where we really show the difference. Yeah, again, we can take the blood pressure if there's not a clinic located in rural America, that's great. But it's the proper drug therapy, to me, is key to what we were educated on. And I think so for us, we're gonna eventually, when we move those other NTM functions into being a medical billing pathway, that will solve it in the way of they can then get credit for, though I feel like they can eventually get themselves be set up to be billed better, and they can get paid for the things they already do, versus collaborating with the physician and getting that whole contracting and blah, blah, blah done, which is a lot of work. If they can just directly bill the state for the things they do, I think that's my hope or goal, solving some of that, so they get the credit for the real-time interventions in the pharmacy.
I'm going to quickly just interject really quick and just be mindful of time, those on Zoom. I'm happy to leave this running, Dr. Smith, too, if you have any comments or response. But I just want to let everyone else know and kind of give a thank you for joining us. But I will leave this running for those who want to continue the discussion.
Thank you so much, Sydney. Annette, is the description, and I hear loud and clear, there's a lot of workplace and workflow challenges. Were you mentioning your experience because you are able to use a collaborative practice agreement, or is it mostly providing recommendations?
I didn't ever work towards any kind of collaborative practice agreement. I just know that I always intervened when I was at the retail pharmacy. I always intervened because that's what we do. That's what we're called to do. That's what we're licensed to do, is to protect the patients. So I intervened there. I wanted to enter my interventions more into the system so we could get paid more, but there just wasn't time. Right. And I don't know if I answered that question. Yeah, so I wasn't really worried about a collaborative practice agreement because you're in real-time setting and not, retail.
Right. So I think that your point's very well taken, that it's difficult given the workflow issues at a community pharmacy level to provide recommendations. And even if you have EHR access and you can document or send some type of an e-care plan, doing that outside of collaborative practice does have a lot of workflow challenges, time-based challenges. Collaborative practice acts, if you have that ability in your state, and you have the ability to develop one of those agreements with a physician organization or a group or a private practice or a clinic, it doesn't require time on the physician side to review your documents immediately and wait, back and forth for communications. But it does take time to develop that collaborative practice agreement. So there are trade-offs, I think, there. And so